I think it's recording.
It is. It
Okay.
says on here on mine.
All right, so tonight we're talking about your cognitive exam. So I think you're all aware of that. You've already completed your psychomotor. So this exam is a large stressor and confidence killer for a lot of students. You've probably heard rumors and had some experience where it seems like it's a really difficult test, right? And you might have heard that it's like impossible to pass the first time. That's not true. Obviously, many of your classmates have passed on their first attempt. So it's totally possible. I'm not going to lie and tell you it's a super easy test, but EMS isn't easy. It's meant to test your knowledge that would allow you to appropriately act as an EMS provider. Okay, so just realize that it's not necessarily designed to be hard, but like I said, EMS isn't necessarily an easy thing, and so it's the best benchmark that we've developed thus far in order to test and make sure that you're ready to start treating patients. By the way, the national pass rate in 2012, that's the year I took mine, 72% on the first attempt. So more than, or almost 3/4 of people do pass on their first time. So it's totally possible. All right. So briefly, I just wanted to review what exactly is covered on the exam. Because I think just knowing what's tested can better help tailor your studying, better help your performance. So the exam's not necessarily just about memorizing facts and figures. It's more about how to apply that information to real life scenarios. So it's broken down into 5 content areas, which we're going to look at in just a moment. And within each topic area, so within those 5 topic areas, about 85% of your questions will be geared towards adult patients, and about 15% will be geared towards pediatric patients. Okay, so as we can see, we've got airway is about 17 to 21. We also have cardiology, medical, obstetrics, gynecology are all lumped in together. Cardiology and resuscitation is going to specifically refer to like CPR type questions, okay? Resuscitative care, shock, and then some like related anatomy and physiology. Trauma is your other big category, and then EMS operations. So looking at the breakdown up here on the slide, what area is going to be tested most heavily on the exam?
Your favorite.
OB/GYN.
Okay, yep. So medical and OB/GYN. So it's all kind of lumped in there together. So that's why that's also such a large number of questions, is because that's a really broad category. So medical could literally be any medical emergencies. So we're talking like neuro, GI, urologic, endocrine, hematology, infectious disease, psychiatric emergencies, gynecology, obstetrics, neonatal care, and then related A&P to all of those systems, secondary assessment of medical patients, and reassessment of medical patients. Same kind of goes for trauma. It's just going to be testing every trauma system, basically. So trauma to any of the body systems is fair game, and related A&P to any of these is fair game. So expect that you'll probably see some related A&P questions to airway, and maybe some also about cardiology. Any questions? Okay. All right. So when you're studying for your exam, just some quick tips to help you study better. So make sure you've got a distraction-free environment. So something like a library works pretty good. The rescue squad works pretty good. If you're not on duty. Make sure you silence your phone, turn off your TV when you're studying, right? Just eliminate all of those distractions, really help yourself focus. But like I said, I think it's really good to kind of get out of your normal environment. That way you're have this dedicated place where your brain knows, hey, I'm going to study now, versus if you're at home, your brain's still thinking of all the other things you normally do at home. Try to avoid studying somewhere like your bed or your couch too, for the same reason. Your brain knows that that's like relax and chill out time, and so it's not going to be motivated to study. Next would be to develop and stick to a study schedule and keep it realistic. So how much time do you realistically have that you can spare to study, right? Don't set an unrealistic goal like, oh, I'm going to, nail 5 chapters a day before the exam. not realistic. So an hour, 2 hours a day, but consistent practice is the key, more so than cramming, right? Consistent practice will prove better results for you. Next would be to maximize your study time. So don't just reread the entire textbook. You already know a lot more probably than you're giving yourself credit for. So use these FSDAP exams that you've taken. There's lots of other free resources out there, but take advantage of everything to really maximize your study time. So like if you did really well in EMS operations, don't spend your time studying that. Focus on medical OBGYN if that's what you need. Studying with friends is always helpful. So peer reviewing, it also helps reinforce the material to you if you can articulate and explain it to someone else, because you have the way your brain has to analyze the information to kind of teach it to someone else. Helps you learn it a whole lot better. So finally, the last one would be to use a variety of tools to study. So we've given you the FSDAP exam. Your book's got some practice questions and exams in it as well. And there's tons of free practice tests. There's the apps that you can download. There's tons of videos. There's podcasts. There's all kinds of free EMS articles online, right? So be creative and use a variety of those different tools. Practicing in different ways will also help you retain the information better. So while practicing the questions is probably one of the best things you can do to prepare for the exam, if there's like a topic area that you're weak in, try doing some of those other things, like looking up some videos. We can send you some, or playing a little game, something like that. Flashcards is another good one to like memorize straight information. So if it's like, say you keep messing up when we're supposed to bag a patient, right? So you could put that information on a flashcard, like respiratory rate greater than 30, and then on the back you'd put bag the patient, right? So those are quick little ways that can help you study. Any questions on any of that? Okay, so now let's actually talk about some exams. So there's all kinds of questions out there, right? Life is full of them. Why is the sky blue? Is there life after death? The first two questions the first question, we got to know something about meteorology or theology. Second one, but as an EMT, we should be able to respond correctly to this question. So an adult male is unresponsive on the floor of a restaurant. Patrons report the patient was having lunch when he suddenly grabbed his throat and collapsed. He is cyanotic with agonal breaths. What should you do next is what that should say. All right, so this, right, as an EMT, seems like a pretty straightforward question that we should be able to answer, right? But what if these are your answer choices? So at first glance, some of these look good. They seem to be right. But if we take a closer look, there's one answer that's better than the others, right? And so that's how your EMT or your NREMT exam is going to be set up. Multiple choice questions in this style, and it's testing your ability to make an accurate decision, right, about the patient. So keeping that in mind, that it's the best answer, not necessarily which one is right, but which one is the most right, or of the ones that are right, what is the best answer, okay? So we're going to come back to this in just a second. So the multiple choice questions that you'll see will always be in the same kind of format, okay? So you're going to have the STEM, and that's the actual question part. So that's the first thing we just looked at a second ago. So that's really just the prompt, okay? It's going to set up the situation that you have to respond to, and it will always provide you the information necessary to answer the question, okay? So somewhere in that STEM will always be some kind of hint or clue or some piece of information that will tell you what the right answer is. Now, that is given that you've studied and you have the knowledge to connect the dots, but there will be some kind of clue in that STEM, okay? So the STEM ends in the form of a question usually, or asks you to complete some kind of statement. All right, and so then obviously we'll have our answer choices. That'll be the best choice like we just talked about. You'll also have distracting answers. So those are designed to draw your attention away from the answer. So You'll have good distractors and bad distractors. There's some that will just very obviously be wrong if you've sat through an EMT class, hopefully. So you can quickly throw those ones out. But we might have that more than one right answer. So that's when we're going to be looking for what is the best. Okay, so distracting. This is just an example, obviously not a good NREMT question, but it's demonstrating our concept here. So you look up and see a small animal with wings flying overhead. As it does, you hear it make a quack, quack, quack sound. So you suspect it is A. Okay. Right. So immediately, like we were just talking about, this has a bunch of bad distracting answers, right? So we can just immediately throw those out because none of those other things make a quack, quack noise, right? But what if we had answer choices that look like this instead? Okay, so unless you're some kind of duck expert, this question's much more difficult to answer. So just we have to have that base knowledge as EMTs to be able to answer those questions. So you're going to have to study some material in order to pass the exam. That's the point we're trying to make here. All right. By the way, the answer is an American black duck.
That's what I was thinking.
I wrote down why it's the right answer.
Because it's small.
The rooty duck makes a belching noise, so that's why it's called the rooty duck. And the other one makes a car sound, apparently. And I think D is not even a kind of duck. All right, so let's go back to that question we talked about earlier. So, an adult male is unresponsive on the floor of a restaurant. The patrons report the patient was having lunch when he suddenly grabbed his throat and collapsed. He is cyanotic with agonal breaths. What should you do next? So give everyone a second to think. And when you think you have an answer, raise your hand. Don't be afraid to guess. That's, none of these are trick questions or anything. Like, we're here to help you get through this. All right. Nathan, you got it? All right. Who said A?
Probably not.
Who says A? Ashley? No? No one? B? All right, one for B. C? All right, and D. Okay, good. All right, so given this situation that we have here, most of these answers are correct, right? So this is when it comes down to what is the best answer. The key here is that the scenario is asking us what we should do next, okay? So when we get a question like this, we're going to talk about these more in a minute too, but what should you do next? So like we just said, that means that should clue us in that there's probably more than one right answer up here, and that more than one of these is going to be an appropriate action, but we have to figure out what order would be the appropriate way to prioritize these, right? So,
What's wrong with the patient?
Not responsive.
Because of?
Food, possible airway obstruction.
Okay, just making sure. So it's choking, right?
Yeah.
okay.
Right.
So
But he's on the ground.
what
Right.
else are they reporting in there?
Cyanotic agonal breath.
Okay.
What does that mean?
It's blue. It's partially blue.
Okay.
Agonal means
In pain.
not in pain.
It's
Dizzy.
Agonal means
Like that. Right?
it means that he's not breathing to substantiate life.
So agonal breaths are usually seen when?
Just before the patient does what?
Dies. Oh.
Okay. So usually we see agonal respirations just before the patient goes into cardiac arrest. Okay. So that's what this question is testing really is, do you know what agonal breaths are? Are you able to put together that clinical picture of, it sounds like he's choking, now he's cyanotic with agonal breaths. So what should that lead us to think here? So cyanosis already, you should know what?
Like a flat box.
Okay, so he's not getting oxygen, right? Good. And so we know he's got likely some kind of airway obstruction, and that's why he's not getting oxygen. And now we've got the agonal breaths. So what should we be thinking? About to what?
Stop breathing.
Okay. All right. So if our patient's not breathing, what would we do?
CPR.
Okay. So CPR starts with what?
Checking the pulse.
Okay. Is checking a pulse an option up here?
No.
All right. So then what do we do? What would be the next thing you would do? So checking a pulse isn't wrong, but what would be the next thing you do after that, since that's just not one of our available choices? Chest compressions. Okay. So chest compressions is going to be the correct answer on this one, actually. So the abdominal thrusts, right, we're obviously only going to do if the patient's conscious. Ventilation is appropriate, but it's going to be performed after compressions, right? So that's the CAB. Don't forget, that order from CPR. And think about it too. So if the patient's heart is not beating and we're not circulating any blood anymore, okay? If we're breathing for them, that oxygen's not going to go anywhere because my blood's not circulating, right? So we've got to get blood into the lungs to pick up the oxygen and take it everywhere else. So that's why circulation becomes more important at this point when they're in arrest, okay? And then rolling the patient on their side while it's it doesn't really like change their condition. Okay, so maybe if they were vomiting and had like stuff coming out of the airway, then that would be appropriate. But they didn't give us that in the prompt, right? Okay. So even though, like we said, there's not information on whether or not he has the pulse, how do we know he's in cardiac arrest? So that's the other thing they're kind of testing you is, are you able to gather from the primary impression or the signs that they're giving you from the patient that he's in cardiac arrest? How do we know?
Yeah.
Diagonal breaths. Good. Okay. Any questions on that one?
Y'all have a crew?
No, we don't have a crew. That's an announcement.
Attention all units.
All right.
Be advised that Chippenham
So,
Hospital diversion is to open.
When you go to, we're going to now talk a little bit about strategy. Like, so what we'll do is we'll talk like kind of one of the strategies or tips, and then we'll like have an example question to try it out. And then at the very end, we'll have a couple of the quote unquote hardest questions that we'll walk through kind of together, just like we just did that last one. Okay. All right. So when you are going to attempt to answer a question, first thing you want to do is read that STEM part that we talked about and try to answer it before you look at any of the answer choices. Okay. So that'll tell you already like kind of what your gut is telling you, right? If you just try to answer it, like I said, without even looking at the answer choices, try to, what would I do next? Okay. Well, we were able to come up with on the last one, like I'd check his pulse. So even though like that wasn't an option, we're checking his pulse because I think he's in cardiac arrest. So what would I do after I check his pulse? Okay, well then I'd probably start compressions, right? So it's a good exercise for you, but it will also make it easier to answer the questions, right? Because if you already have in your mind an idea of what the answer is, then all we have to do is look and see do one of those answer choices match. So that's what you're going to do next. You'll compare them to your answer choices. The STEM part should be written well enough that you should be able to answer it or come up with some kind of answer without looking at the responses. Okay. Like we talked about, there should be some more information tucked in there. Also, this is going to be a helpful strategy in getting you to slow down, right? And so it's reducing some of that test anxiety. Slow down, read the question, think of that answer, and then consider the answer choices. Okay. You might have to draw certain conclusions about the patient's status, just like we had to in the last one, right? We had to conclude that they were in cardiac arrest based on that information that's provided in the STEM. And sometimes making that conclusion is going to be the key to finding the right answer, okay? So what do we do if your answer doesn't match one of the choices? Okay, so we're going to give you another prompt to consider here. I'll read it because I know the text is kind of small. Sorry about that. So a 62-year-old female is experiencing chest pain that began at rest. She describes the pain as sharp and points to the right side of her chest when you ask her to locate where the discomfort is. Her heart rate is 90, her blood pressure is 130/70, and her respiratory rate is 16 and non-labored. Her oxygen saturation level is 97%. You should. Okay, so let's think about that for a sec. I purposefully haven't put in any answer choices up here, right? Because let's try and answer it without looking at any answer choices. Okay, so what is, we're going to talk about this method in a second too. Let's start with what's the patient's mental status?
Alert.
Okay, they're alert. What about, what's their chief complaint?
Chest
Okay. Is there anything in the prompt that tells us if this is an acute patient or not? Are they a critical patient?
pain.
Okay. Why do we say no?
Vital signs of health.
Okay. Good. Yeah, her vital signs look good. So we've got a normal respiratory rate. We've got a good oxygen saturation. BP is a little elevated. Heart rate's a little elevated, but not dangerously so, right? So then what would we do next? So is she a stable or an unstable patient?
Stable.
Stable. Okay, so we have stable chest pain, right? So what would we do next?
Administer nitro. It's prescribed.
Okay. Good.
Aspirin.
Aspirin. Good.
I guess she has an inhaler. I guess she's also.
Okay.
We would ask her about events leading up to it.
Okay, so maybe some more history taking. All right, so these are all good options that could be viable answer choices, right? All right, so now if we have these answer choices, what would you want to do? C. All right, and that is the correct answer, is C. All right, so why would A be incorrect?
Sure, oxygen is basically always at 100%.
Good. Okay, so she's already at a good O2 sat. Definitely, if we were going to give her oxygen, what would we probably give her?
Nasal cannula.
Good. All right. So B, we identify, why is B wrong?
Because she's
Because she's
not.
not in any critical care.
Right.
She doesn't need critical.
Right. So we said she's not a critical patient, so she don't need to be rushed to the ER. And then what about D?
Not helping. She said it happened at rest. Yeah.
Okay. What do you think they're getting at with put the patient in a supine position?
Like pressure.
So think of it in terms of treatment. What kinds of treatment there we go, shock, okay? So does anything indicate that the patient's in shock? Nope, so D is also not correct. So C is our best answer. All right, and we've kind of been doing this all the way along, but this one I think we're all pretty familiar with, but eliminate whatever answer choices are not right, okay? So if you have to, make an educated guess between 2 or 3 of the choices, that's easier than guessing between 4 different choices, right? So if there's one that looks obviously wrong, go ahead and eliminate it, and then try and go through and ask yourself, why would these other ones be wrong? So, does that answer choice have a relationship to the stem? So if we look back like at that last one, right, like transport immediately. Well, when we look at the stuff that's given in the stem of the question, transport immediately doesn't really make sense. There's no relationship there. There's nothing that indicates this patient needs immediate transport. All right, so let's take a look at this one. A 20-year-old female was struck in the chest with a bat during a fight. She complains of chest pain and trouble breathing. There is tenderness when you palpate the left anterior chest wall in the area of T3 and T4. Lung sounds are clear and equal on inspiration. She is alert and breathing 20 times per minute. Her pulse rate is 90. Which of the following injuries is most likely? Oh yeah, so before I show you the answer choices.
They broke.
All right, so we've got rib fracture, good. What else could it be? Okay, so it could be, and a flail chest comes from what? Okay, so rib fractures, flail chest is a phenomenon seen with rib fractures, okay?
Spontaneous pneumothorax.
Okay, so some kind of pneumothorax, right? What else? Anybody? Okay. All right, so now let's look at the actual answer choices. So we've got a tension pneumo, rib fractures, a pneumothorax, or a pulmonary contusion. So, so we've got, so let me ask you, Jacob, since you said A. What indicates tension pneumo versus just simple pneumo in the question?
Correcting the chest.
Huh? Okay. What's a tension pneumo?
I know like pneumothorax is like not like when in like a hole, and it like creates negative pressure inside it. I guess tension is just negative pressure that's inside of it.
Okay. So
I went off this look.
there we go. Okay, so you
What did you say?
Air in the pleural space is putting pressure on the lung.
your lung, right? And then surrounding the lung is this like other layer, really thin layer of tissue, right? Okay, so normally it actually should be like right up on our lung. Okay, so normally there's barely any space between the two, and it's like plugging right onto your lung like this. In a tension pneumo, somehow air gets in this space in between the two, and it's going to start to make that lung collapse. Okay. Does that make sense? So air is getting in this space and is putting pressure on the lung and is making the lung actually collapse. So all of your organs, right, are surrounded kind of in these little layers of stuff. So all of your organs pretty much, like I said, have some kind of little layer of stuff that goes around the outside. So when this happens to the heart, we have another name for it, okay? But it's the same idea. When the blood or air builds up in the pericardium, it's going to cause cardiac compromise. So if we have blood or air building up in this pleural space, okay, that's what we call it, it's going to cause respiratory compromise, right? So do you guys understand what I'm talking about? If not, maybe Andy or someone can explain it in a better way.
You would normally see like tracheal deviation in a patient with a tension pneumo
Okay.
as well. Severely diminished lung sounds, tracheal deviation. Although tracheal deviation is a late sign and usually it's low, you can't see it as much, but.
All right, so final answers. What do we got, guys? Take a stab.
I'm allowed to change my answer.
Yeah.
B.
Okay, so you're going with B?
I would have thought B,
B? Nathan?
but I'm questioning it.
B. Okay. Well, you all should be proud. B is the correct answer. Okay. So let's talk about why the other ones are wrong. So we kind of talked about the tension pneumo. What would be some other signs that we might see in a pneumothorax? Think back to your trauma assessments.
There wouldn't be clear and equal respirations.
Okay, very good, right? They definitely wouldn't be clear and equal.
Either, any of them other than the rib fractures.
Good. What else might you see or would we be expect to be given? All right, so if they want us to know, right, that it's a pneumothorax, because right now there's no way to really differentiate that, but what additional information might they give us that would tell us it's a pneumothorax? Okay, so some kind of chest wall wound, good. What else?
Bubbling.
Well, Andy already mentioned the, deviated, tracheal deviation.
Good. All right, and what's another one that we might see specifically with a pneumo right in the same area?
JVD.
JVD, good, okay.
That's the one I was referring
So they didn't give us any of that kind of info, which, like I said, if they are trying to push you towards a pneumo, and these were, you know, your answer choices, we'd have to have that additional information to determine that, okay? If it was a pneumothorax too, we'd also expect, right, a faster breathing rate. We'd have difference in the lung sounds, like Ashley said. And then finally, if it was a pulmonary contusion, what does that mean? What's a contusion?
Bruise.
Bruise. Okay. So it's literally bruising to the lungs. All right. So it's just kind of, you know, an uncomfortable injury. It's going to make them breathe a little bit faster, have a little bit more strained effort to breathe. But beyond that, no other real symptoms. But rib fractures is the most likely answer. Any questions on that one? And so your gut was right too, right? So before we looked at this, before we looked at any of the answer choices, right? What was the answer you said? Rib fractures, okay? So that's also why I said that's a good practice, and a lot of the time your gut is actually going to be the right answer. Don't get distracted by the other ones that are up there. Yes, sir.
How do you get a pneumothorax without like an open in the chest?
So you
Get the
could,
rib fracture.
yeah, you could have a closed, like a closed rib fracture. You know, the little jagged piece of bone pop the
Puncture
lung.
lung.
But yeah, and because it pops lung, it's not a tension.
Right. So the tension pneumothorax is specifically referring to that pleural space. But if I get, so just like, you know, that breach in the chest like wall can introduce air into the thoracic cavity, which is our entire chest where lung and heart is sitting, right? And so that can also cause the pneumothorax that way by air being just in the chest cavity, not necessarily in that pleural space. So if it's in the chest cavity, instead of pressing in between these two layers, right, the air is just pressing out here. It's just pressing down on both of them. So it's going to really cause the same thing, or cause the same symptoms, but the root cause is different. Does that make sense? We are going to treat them both the same as far as EMS goes, other than if there's some kind of open wound, what do? Open wound on the chest. Occlusive dressing, very good. All right. So yeah, using what we just talked about, you should be able to eliminate some answer choices. If you end up having to select between those two, consider these tips, and then we're going to talk about one last strategy. All right, so reread the stem to detect any clues that you might have missed. Sometimes the best answer is the longest one because the test writer provides an explanation or extra details to make it the best answer, okay? But that does not necessarily mean that every single time the longest answer is going to be the right one, okay? So this is if you really have no idea, last-ditch effort, it might be the longest one, okay? They also, another note on that, the people that write the exam, you know, they do kind of check for those type of writing errors or whatever that they call them. So I'm not saying it's likely, but again, you never know. All right. If the answer contains some kind of absolute word, it's not likely to be correct. So if it says something like always or never in the answer choice, it's probably not correct because most situations in EMS are not that clear cut. Most situations in real life are not that clear cut. So if a question, like if we get some of those sequencing questions, which a lot of them are, right? Because it's testing your decision-making ability. So things like, what do you do next? So if it's a what do you do next, we want to check the question and see what we've already done, number one, because it's saying next. So we've probably already done something. And then what is the next thing we should do sequentially? Okay, so I've already done this. So then I would do this thing sequentially following, right? And if it's going to ask us what should we do first, that means that there's probably multiple right answers again, but in what order would we do them? Okay, so if it's first, again, that means there's probably multiple right answers, but we have to figure out which of them or what order those right answers go in. Okay. All right, so let's do it again. We have a 19-year-old male who has been shot in the chest. He has an open wound to the left anterior chest wall that is oozing blood. He responds incomprehensibly to verbal stimulus. His respiration rate is 8 with shallow breathing. His pulse rate is 110, and his skin is cool, pale, and diaphoretic. What should you do first? Okay. So give you a second to think about it. Remember, first means that we might have more than one right answer. So what should we do?
It's trauma.
Yeah.
It's trauma, so you go cab, so C, cardiac, open chest wound,
But his
death.
his
Seems
respiration
like
rate
they
is
throw me off
8.
because there's no like occlusive dressing on them.
Okay.
My God.
So
Yeah.
let's start there then. Okay. So if you're not sure quite how to tackle that question, right? So we know that occlusive dressing would be the appropriate intervention based on what they gave us. So answer choice C is apply gauze to the open chest wound. So is that the correct answer? Is gauze an occlusive dressing?
No.
No. Okay. So C is incorrect. So if it said apply an occlusive dressing to the open chest wound, that would be a correct answer. But since it says gauze, that's again a distracting answer, so we can eliminate that one. Okay. So now you've got 3 options.
It's not going to be A either
Okay.
because he's responding.
Okay.
He would have okay.
Yep. So he's got it. He responds to verbal stimuli, right? So that gag reflex is likely to be intact still. So we wouldn't want to insert an OPA until they're completely unconscious.
B because his respiration rate is 8.
Okay.
Yeah, it's so low, you'd need to do bag valve.
It's less than 6 and greater than 30, but
Okay. What else does it tell us about his breathing?
Shallow.
Shallow.
Okay.
Inconsistent.
So if we have 8 shallow breaths, okay, so let's think of a shallow breath as a half breath, right? So if we're taking 8 half breaths, I've really taken the equivalent of how many normal breaths? 4, okay? So then are those patients' respirations at 8 and shallow adequate to sustain life? No. All right? So like I said, think of it if that number's on the border right there like that, right? 8 is one of those, it's right on the border. They give you that other hint that it's shallow breathing. Okay, so we know that shallow breathing is not normal breathing. And at a rate that low with shallow breaths, we can conclude that the patient's breathing is not adequate to sustain life. So we need to intervene. So which is the best answer?
B.
B is the best answer. Okay, why would D not be appropriate?
that would be more
They're not.
if he was unconscious or breathing for shock at that point.
Okay. And more so, like we just talked about, because they've got that slow respiratory rate, they have that shallow tidal volume, so they need more air. What that patient needs is not oxygen, they need more air getting in, okay? All right. So, do you wanna explain this one since this was
I got this from a book.
okay? I mean, I can do it if you don't want to. All right. So the 4-step method. If you're still, if those other tips aren't working for you, the goal of this was to give you guys a variety of strategies that you can use to tackle the questions. I promise if you use All of these, you're gonna be solid. Okay. So, first thing we're gonna do if we get a question and we have no idea how to tackle it. Okay. First thing I want you to do is determine the mental status of the patient. Okay. Then I'm gonna break these down further in a second. Okay. So we're gonna look for signs of criticality. So is this a critical patient or are they a stable patient? We're going to determine the patient's chief complaint, or not necessarily chief complaint, but what is the patient's complaint? What's their problem? And then finally, we're going to look at any vital signs that are given to us in the prompt. All right, so as far as mental status goes, if the patient is complaining of something in the question, so they tell us that the patient complains of, that is reasonably, we can conclude that they have a normal mental status for the most part. Anything else, they will pretty much give you a specific description for some sort of negative mental status. So if they're unconscious, if they're altered, if they're sleepy, if they're acting abnormal, there will be something in the prompt that tells you that, right? Does that make sense?
Thinking about it.
Yep. All right. So then the next thing will be to look for signs of criticality. Okay. So is this a critical patient who's about to die? So do we have things to keep an eye out for? So signs of respiratory or cardiac failure. So like we just saw in that last question, is the respiratory rate adequate to sustain life? Is the respiratory volume or quality adequate? Has there been a change in their mental status? So, really any patient who's altered is obviously going to be more critical than a stable patient. Altered alone doesn't necessarily make critical, but if we're like unconscious, right, that's a little bit more critical too. Okay. And then, like I said, definitely any change in mental status is usually a bad thing because our patient's usually deteriorating at that point. So that's also going to be a critical patient if their mental status is deteriorating. Poor skin color. So what would be some descriptions that you might see in a question of poor skin color? Pale. What else? Cyanotic. What else might they say?
White, hardened.
Yeah, so like maybe gray, ill appearing.
Andy.
I said hardened.
He said hardened, yeah.
Well, that was one of the
That's
questions
not
I had
a
on
color.
someone. It was like, you have a 25-year-old female. She's skin's like white, and she's skin's hardened.
Frostbite.
Yeah.
Oh. Skin is stiff.
Okay,
Like that's not a
what
color.
else would be something that's not necessarily up here, but that would be signs of a critical patient? Think also in terms of skin.
Poor cat.
Okay, good.
Weak and gritty pulse.
So skin. What else do we assess about people's skin besides the color?
Warm.
Warmth, okay. And what else?
Open wounds.
Okay. Think of like I said, think of what a
Oh.
critical patient. What are you gonna see?
Wet.
It's like
There we go.
Moisture.
Okay, so kind of anything extreme, think of it that way. So, normally the skin should be kind of warm. It shouldn't be too hot, right? But if we touch them and the patient is like hot, so think of like, you ever touch somebody with like a sunburn, like the skin is very warm, or like a patient who is septic, they tend to have elevated temperatures and there will be lots of heat coming off that body. Same going the other way, if they're extremely cold, that's a problem too, obviously, because their skin should normally be warm. And then same with the color, right? So if we're like extremely pale, extremely blue, right? Normally the skin should have a little bit of a reddish, pinkish kind of tone to it. So if we have a lifeless patient, right? So somebody who's exhibiting these critical signs, don't forget that it's a CAB approach, okay? So it's not ABCs anymore. We do CAB. So what does that mean?
circulatory, airway, and then breathing.
Okay, good. So that we're going to address any problem with circulation first. So whether that's a bleed, whether that's cardiac arrest, we need to address those problems first, because like we talked about, if we're not circulating anything, then it doesn't really matter what I do to the airway or breathing, because the patient's not going to get the oxygen anyways. So we've got to keep them circulating. So what would we check first on a lifeless patient, on a patient who is appearing lifeless? Pulse. Good. Okay. All right. So third step after we've determined, so we've decided what their mental status is, we've decided whether or not they're critical. Then after I have that information, then I'm going to say, okay, so what's actually going on here? What's the patient complaining of? What's their mechanism of injury? And then is whatever this patient is complaining of or whatever injury they have, is it something time sensitive? So is it something that I need to get them to the hospital quickly, or is it something that I need to intervene with some kind of medication or treatment very quickly? And then also on that same token, like I was just saying, does the complaint indicate that I need to do some kind of treatment for the patient? So what are some examples of a time-sensitive complaint?
Widowmaker.
Okay, so acute MI, good, STEMI, acute coronary syndrome, they're all synonyms for the same thing. What else?
Bleeding.
Okay, so some kind of major bleeding, good. And that's, a stroke could be a major bleed, but we could also have,
Blunt force trauma to the head.
okay, so head injuries,
Under shock.
signs of shock, good. And then major trauma is your other really big time-sensitive thing. Okay. Good. We're going to move on to the next. So finally, the last thing we're going to do when we're trying to figure out where to go with our question is, after I've determined those other three things, we're going to examine the patient's vital signs. Okay. So normally, if they give us bad vital signs, and that's the first time it's registering to me that this is a critical patient, stop right there and go back and reread the prompt, okay? Because normally in their style of questioning, abnormal vitals are going to be found with a poor patient picture, okay? So that's what we're determining really in those questions 1 through 3, is I'm getting my overall picture of the patient. I'm making a general impression, right? We taught you guys the triangle thing. That's basically what we just talked about, right? We talked about looking at their mental status and their skin and their breathing for the most part. So once we've got that picture hopefully formed, then we'll look at those vitals. And we're really just asking ourselves, are these vitals abnormal, or is this reasonable for this patient? And again, do the vitals indicate that the patient is critical? Any questions? All right, so let's try another one using the method we just discussed. So you determine that your unconscious patient has an inadequate airway. You insert an oropharyngeal airway. The patient vomits. You should first, A, place the patient into a prone position, B, remove the airway, C, suction the airway until it's clear, or D, place the patient in a sitting position.
So like,
All right, so first things first, remember, try and come up with your own answer in your head first, just based on the stem. My patient's unconscious, they don't have a good airway, I put an OPA in, and they vomit. Okay, so in the order of events, just like that. So what should you be thinking as an EMT first?
their airway now has vomit in it.
Okay, good. Okay, so we got to do something about that. So using the method we just talked about, what's the patient's mental status? Good. Are they critical or not? Why?
They're inadequate.
Good. Okay. What's the patient's complaint? Unconscious. Yeah, that's a good one.
Unconscious and difficulty breathing.
Okay. Yep. So respiratory failure, unconscious, airway compromise. All of those are a good, kind of clue for patient complaint. And we aren't given any vitals, right? So we can't draw any information about vital signs from there. All right, so what do you think is our best answer up here on the slide? So again, we've determined that they are unconscious, they're critical, and my complaint is likely something respiratory airway related, okay? So given that I know those three things, that this is a critical patient, they're unconscious, and the problem is likely to do something with their airway or respiratory system, what up here is the best answer?
What should you do first?
Okay, so yeah, and what did we say that first means? So if we see first, that means what?
After.
Okay,
So B
determine the
technically can't be the answer because that's not saying remove the oropharyngeal, it's saying remove the airway, and the airway is inadequate. But that's not the apparatus that's in it, it's saying remove, it's literally saying remove airway, right? Or is it just,
Pretend it says remove the OPA.
yeah, pretend it says
Okay.
remove the
Yeah.
OPA.
okay,
Technicality.
So remember that
Yeah.
this keyword
Well, I
here
mean,
first
if that was
means that
written
they've
there.
probably given me
Okay.
more than one answer up here that is an appropriate intervention in the situation. But like Andy said, we have to sequence them and figure out which one is the thing I got to do first.
Right, like you're obviously gonna suction the airway eventually,
Okay.
because you just vomited.
So what would I have to do? So also, with these kind of questions, go back and again, like I said, reread that stem. What have we already done? Because that maybe will help me know what I need to do next.
You inserted an OPA.
Okay, so I inserted an OPA. We put the OPA in and the patient vomits. What do?
You remove it.
Remove the airway, right?
Then what do you do?
Suction the airway until it's clear. Then
Good.
you can re-enter the OPA.
The vomiting indicative.
Well,
that
then
they
you
still
do
have
a
the
nasal, I
reflex?
think.
What?
Could the vomiting
Well,
be like indicative that they still have a gag reflex?
That's exactly what it's supposed to indicate. Okay, so that's likely what happened. Again, we're, like I said, they were expecting you to be able to draw conclusions about what's happening here. So that would be real life, right? We have an unconscious patient. We don't know what's going on with them. We put that in, they start vomiting. This is what, that's exactly what we would do. So would A be appropriate?
No.
No. A should never be appropriate. We should never place the patient.
No.
And so then, like we said, C would come after B for sure.
D would probably be like when you're transporting.
And D would also be incorrect because of
What?
Unconscious.
good. Okay, and especially also with airway compromise, what's the position that we put the patient in? So think of, again, unconscious patient, we're going to open the airway.
Supine.
Okay, supine, and then we do if it's just a normal, non-trauma patient, what do we call that thing? Head tilt, chin lift, good, okay? So that's right, got the head back like this, but think about it, if you're sitting up, this isn't really an open airway, nor is there a good way for me to keep the patient's head like that, okay? Good. Okay, do you have any questions so far on any of those strategies? What questions do you have? Yes,
So at that point,
this,
Oh, yeah, I do. Sorry, do you want to go first?
so at that point where they vomited when you put an OPA in, are you just gonna go to an NPA at that point?
good, yep, but it would, at what sequence would you move to the NPA?
After you suction?
Good.
Yeah.
Yep. Okay,
Suction, readjust the head.
Yeah.
Yep.
And then.
good,
NPA.
exactly.
Can you go over like this again? Like I know you went over earlier. Can you go over the specific signs of like the respiratory failure and cardiac arrest?
So respiratory failure. So if the patient's not breathing, that's obviously respiratory failure. But then if we've got, think of it, I like to think of these things like as the extremes, right? So if we're either breathing too slow or breathing too fast, those are both critical patients, okay? So that the extremes on either end. And kind of same with our pulse and blood pressures, right? So if we have a really slow pulse, that's a bad thing. If I have a really fast pulse, that's a bad thing. Now, there's another thing up here that says narrowing pulse pressures. What does that mean?
They're just closing like in on each other.
Okay, what's closing in on each other?
Systolic.
Good, okay. So the two numbers on my blood pressure are getting closer and closer together, all right? So our diastolic and systolic blood pressures are getting closer together. That's called a narrow pulse pressure. That also means for us to notice that, they'd have to give us more than one set of vitals in a question. So if you get a question that gives you more than one set of vital signs, it would be very prudent for you to compare the two sets, because there's probably some kind of information in there that you are supposed to interpret between those two sets of vitals. Most of the time, you get one set. Like I said, that should be a big clue. If you get a question that's got two sets of vitals in there, you should definitely compare the two and ask yourself what's changed.
What are the critical skin signs again?
So that would be any sort of abnormal color. So we got pale, cyanotic,
Cool, clammy.
cool, clammy,
Wet.
and then, like I said, kind of on the other extreme end of the skin would be if they're really, really hot and dry. So, normally skin should be warm and dry, but if you're hot and dry, right? What should normally happen if you get hot? Sweat, right? So if you have really hot skin but no sweat, what could that be an indicator of?
Heat stroke.
Heat stroke. How do we determine heat stroke versus heat exhaustion?
Almost dying.
Okay. So actually the key differentiator between the two is going to be the presence or the absence of sweat. So once you reach, you start at heat exhaustion, and once you lose that compensatory mechanism to be able to sweat, now you're in heat stroke. I have seen one or two questions about the heat stroke thing, so that's a good just kind of review point for you there too. Like I said, hot skin that is dry, especially if you expect that the patient should be sweaty given, their environment or something like that. That's it. Huh?
Are you talking about heat stroke, heat exhaustion?
Yeah. All right. What other questions do you guys have? We have a couple more questions still to practice, but I just kind of, before we jump into those, want to make sure we got anything else. So you feel like any of those strategies will be helpful?
Yes.
Yes.
100%.
So guys make a whole new game plan to go.
What's what section does?
Could we have
stuff
done
go
this
into?
earlier?
Yeah,
What section would the heat strokes?
Environmental.
That would probably
No,
fall in your medical.
Sorry.
Mhm. That'll be a medical.
Yeah, no. Environmental. You ultimately had two heads.
There
I
will
was
prob-
thinking something else.
There's
And
probably a
feedback,
chapter
right?
in the book specifically on environmental emergencies
Yeah.
or something like that will cover heat exhaustion, hyperthermia, hypothermia, frostbite. Thankfully, we don't see that too much around here. I would say you'd
Good luck.
see heat stroke, heat exhaustion would probably be the one we'd see the most around here. But heat exhaustion more so than heat stroke.
I had one when I was 8 years old.
Really?
Mhm.
I've had one heat stroke patient when I was working in the city. They were sitting in some hot ass car in like full on like winter jackets and stuff. I have no idea what was going on, but we pulled that guy out and he was completely unconscious and took his temperature and he was like 105. I'm like, oh my God, he's cooking
I
inside.
was hospitalized for 3 days.
Oh my. All right, so these are some questions that Andy found that are
Titled the 5 most hardest questions. The 5 hardest questions on the NREMT exam. So maybe you'll see these.
the 5 hardest questions on the NREMT exam. So use whatever strategy you want from the ones we just discussed, but really the best strategy is honestly to use a combination of them. So, you should always try to eliminate answer choices. You should always try and answer it yourself before, looking at the choices. But then also, if you're still stuck and don't know how to like tackle the question, use the 4-step thing we just talked about.
I know what it is now.
I was gonna say, do you have the explanations for all these? Because I actually was questioning why it's like how you have enough information to determine this versus this and this one.
Yeah, I don't because it was a podcast
Mm.
by the former executive director of the National Registry.
Huh.
And he's the one who answered this question.
Hmm.
He answered all of them. But his thought was where
That's what I was thinking too.
and then that these are not really this critically.
Oh, that's true.
Yeah, so and then this is kind of elevated a little bit.
We would expect
this
to be lower if it.
This is,
Okay.
technically factors into this, but also can factor into this. It's just mainly context clues of this part for the most part, and that these two aren't exactly, this is like mildly.
The thing I hate about these questions is I tend to overthink them when the answer is much more
Yeah.
straightforward.
Okay, I have this too, that they can practice on. And then I've got, what do I should do?
I've got 1,000 some question test back.
I got
Everybody got a guess yet?
Yes.
Is it the right one?
Yes.
All right. So, Jacob, what do you think it is? What A, B, or A, B, C, D?
B.
Okay. Ashley, what do you think?
C.
Okay. Nathan, what do you think?
He's like, damn.
He's like, I don't want to answer.
Join my side.
What's your gut tell you this time?
All right. So, Ashley, congratulations. You are correct. It is cardiogenic shock. And this is kind of what Andy and I were just talking about up here. This is definitely a hard question. Okay. So let's use our 4-step method and start with the patient's mental status. What's their mental status?
They are drowsy.
Okay.
Drowsy, so they're
conscious.
conscious.
Conscious, but maybe altered, right?
Yeah.
So drowsy is not, drowsy should be an indication. You should consider that as an EMS provider in terms of your test, unless that they tell you something like, oh, the patient's like, didn't sleep well or something, but drowsy usually should be an indication of like an altered mental status. So think of like diabetics can get kind of drowsy like that. Low oxygen can make you feel like that. So anyways though, okay. So we're going to say he's altered mental status. Is he critical?
Well,
Yes.
yeah.
Okay. Why?
He got stabbed in the left side of his anterior chest.
Okay. So we've
It's
got
near his heart.
pretty severe trauma, and it's near his heart. Very good. And how do we know it's near his heart?
Left side, anterior chest.
Very
No
good.
matter what size knife, it's close.
Good. Okay. So that's testing. You remember how I said they're going to throw A and P knowledge in there? So it doesn't necessarily ask you what side of the chest the heart is on, but that's the key piece of information really to answer this question correctly. Okay. So we said he's critical. How else do we know he's critical besides his mechanism of injury? Cool, clammy skin. Good. And what else might tell you that he's critical?
When you look at his vitals, his pulse is raised in combination with the clammy and cool, and his BP, while we don't have a second one to go off of, it seems that those are going to get close.
Okay. Yep. So he's starting to get a little hypotensive. The BP is lower than probably what we wanted to be. The pulse is ticking up. Good.
And the respirations with the SpO2 going down.
Good. Okay. So now we've determined they're critical. He's altered, right? So what do we think's going on with him is the real question here. Okay. So what is that patient complaint? What's his condition is what they're asking us. So what is metabolic shock? What does that mean?
Metabolism.
Yeah,
lack of new
so
travels
you-
or whatever.
You see that,
You go into shock due to lack of local nutrition.
Yeah, so it's a problem with like the normal bodily processing, right? So lactic acidosis is a good one that is a type of metabolic shock. So you have a buildup of acid inside the blood. Lactic acid is naturally produced by the muscles, but if your body's not ridding it efficiently, so if you say like have kidney failure or a kidney injury or any number of things, but you'll get this buildup of lactic acid, and that acid changes the pH of the body, affects all of the chemistry that's going on, and will actually produce shock in the body. Okay, so that would be a form of metabolic shock. Not going to be something we're really able to diagnose very well out here in the field without looking at lab work and things like that.
diabetic
Um,
shock, would that fall in with that?
possibly, yeah.
I mean, I get this doesn't give you, oh, he's diabetic, so that would also.
And some other things like maybe like hyperkalemia or hypokalemia. So that has to do with the potassium levels will start to mess with your heart. Okay, so those could be types of metabolic shock, and they have to do more so, like I said, think of them as like the chemical processes of the body. Okay, what does hypovolemic shock mean?
There's a low blood in your body.
Okay, so yeah, it means low volume, literally. Okay, so there's a low blood volume. That's what hypovolemic means.
That's
So-
what I was thinking. Yeah.
All right. So what additional information would
Pooling
Might-
of blood.
might they
would-
give us
Cooling, I guess.
if if these were our same answer choices, right, to point us towards hypovolemic? What might they tell us?
Pooling of blood,
Okay. So yep, if there's
pale. He's cooling clammy, but they didn't say he was necessarily pale and pooling the blood. So
Okay. Good. So if it was something else, yeah, that he's lost a significant amount of blood, that would be a good indication. There's a large amount of blood on scene, another good indication. But we talked about it means low volume, right? So if it's hypovolemic shock, this is probably going to be lower than where it's at right now. So that's really the only other way we can determine it based on the information given here. Is that honestly that blood pressure is a little too high and the SpO2's a little too good still for us to say for certain that it's hypovolemia.
And the pulse is only 18 beats higher than tachycardia. It's not horribly tachycardic either.
Because think if if in terms of a major blood loss like that, every single heartbeat we're losing blood, right? And in a bleed situation like that, so those vitals are going to tank pretty drastically, pretty fast if the patient's bleeding out somewhere. All right, what does cardiogenic mean?
the heart.
Yep. So that gin,
The heart's not pumping enough blood, right?
right? Yep. So gin, that little like root in there generally means like birth, life, generation, right? Genetics, right? So it's shock that starts in the heart or that's caused by the heart is what cardiogenic means, okay? So like we talked about, given that it's on the left side of the chest, it's most likely cardiogenic shock because the heart has been affected, okay? So we don't know necessarily how deep the stab wound is. We're not given any kind of that information. We're not given anything about the patient's bleeding. So this is simply just a question about based on the mechanism of injury and those vital signs, right? And finally, anybody know what a distributive shock is?
Like, they're unable to, like, I guess, what, like, distribute something like in the body. Just go on.
Sort of. It's not entirely wrong. It kind of has to do with kind of your ability to like distribute, I guess is a good way to think of it. But like I'm trying to think of the best way to phrase this.
It's associated with like anaphylaxis, sepsis, deals
So
with
like
tissue.
So like a burn.
when you've got inflammation in different parts
Yeah.
of the body that you're not able to perfuse the tissues properly, right? Because we've got too much inflammation. Okay, so think anaphylaxis is a great example. We got this massive, very rapid swelling that's going to make it, anaphylaxis is a type of shock, right? We call it anaphylactic shock. It's a form of distributive shock or obstructive shock sometimes because it prevents us from being able to either get air or blood around properly.
Or is it like inflammation which restricts the flow of blood and air?
Yes.
In the body?
Yep. So sepsis is another good one. The body gets, it's called, another name for sepsis is systemic inflammatory response syndrome. But that's because you get a bacteria into your blood and now your entire body is literally on high alert and inflamed trying to get this bacteria out of your body, and it's getting into every single one of your tissues. Okay, you guys ready to move on to the next one?
Oh, maybe.
Do you want me to go back,
Are there,
Nathan?
like other types of shock that we should, I mean, I know there's.
You should study all types of shock.
Yes. So that's
Just go over the other ones real quick.
that one section on the exam, right? That's cardiology and resuscitation. Resuscitation, that section will cover shock too. Okay, so shock will be, either resuscitation, so cardiac arrest questions or shock questions will be around 20% approximately of what you're going to get on the test. So definitely review those.
What are the other types?
Distributed, cardiogenic,
Neurogenic.
obstructive.
Neurogenic would be an injury like to the brain or brainstem.
So would a brain bleed lead to neurogenic shock?
I guess actually neurogenic is not necessarily the brain, it's actually more spinal trauma. So it has to do with the nerves themselves and not the actual brain. So something has impacted the spinal cord and now I'm not breathing or circulating appropriately because I have an injury to the spinal cord. So remember that all shock, right, has to do with this idea of I'm not getting enough either blood to my target tissues, or I'm not able to get enough oxygen into my blood and then out into those tissues. So it all has to do with that idea of perfusion, right? So that we're getting an adequate amount of blood, oxygen, and nutrients to all of our bodily tissues. So if anything starts to affect that perfusion, or we reach a state of hypoperfusion, so low perfusion, that's when we're in shock. And so the different types, so to speak, just refer to what the cause of that hypoperfusion is. So there's lots of different,
There's like the lack of air.
lack of air.
Or lack of like breathing, or like.
Pulmonary shock?
Like obstructive would probably be what you're talking about. It's more of a like tension pneumo, that sort of thing. So the cardiogenic, you have to look at it as being a pump problem. So there's a problem with the pump. That's probably the easiest way to remember that one, that you have something wrong with the pump. So
Cardia.
heart, stab, narrowing pulse pressure is another sign in Beck's triad for, what's Beck's triad for? Muffled heart tones and JVD are the others. What is it for? What's Beck's triad? What does it tell you about the patient? What's wrong with them? It's a traumatic injury. Muffled heart sound, muffled heart tones, narrowing pulse pressures, and JVD.
I know what's going on though.
What's going on?
There's blood around the heart.
In the pericardial sac. So what's that called?
Is it?
So one starts with a C and means the heart.
Congested.
Nope.
No.
Cardio
Oh, is
means
it?
heart,
Chronic,
Cardiac,
cardiac arrest.
and then the other
It will
one
lead to cardiac
means
arrest.
it's a word that starts with a T and it means to like put pressure on what tamponade. Yeah, cardiac tamponade. So for this one, another probably context clue would be I have a narrowing pulse pressure. This is over the heart. I've got some tachycardia. Maybe it's a cardiogenic sort of thing. And so that's another context clue for that. Hypovolemic is pretty cut and dry, like you're losing volume. That's pretty easy to know. Cardiogenic, obviously the pump problem, so that could be an MI, that could be a stab.
It could be CHF.
Yeah, it could be anything that affects the actual pumping mechanism. Distributive, we talked about sepsis, anaphylaxis. Probably the ones you don't see we don't talk about much is like obstructive, because it deals with like a pneumo and like, how often have we seen a pneumo? Probably, like I've probably never seen a pneumo. Or tamponade, I don't see tamponade. And then metabolic. So the metabolic, you can think more like acidotic respiratory sort of shock. And that deals more with your like, but less with the structures of the lungs and more of like the acidotic piece, the lactic acid piece, that sort of thing.
Metabolic or respiratory acidosis, like he's talking about, has less to do with the fact like your oxygen or whatever could be fine, their breathing could be fine, but the problem is that they've got too much carbon dioxide and they're not getting rid of it appropriately. So that in turn will dissolve into the blood and make it acidic. And like we talked about, it's kind of a chain reaction of events that's going to start to happen.
So if it was a carbon monoxide alert call, then you might be thinking metabolic shock.
Yeah, it could potentially.
Did you guys say?
Or someone who say was in respiratory arrest, but is now, but maybe now they're maintaining like breathing on their own, but their vital signs are going to be all jacked up. So definitely anyone like in any kind of post-resuscitation state generally is going to kind of start to develop acidosis because for a while they haven't been circulating or whatever, and so all that stuff has built up in the body.
Where did you say a cardiac tamponade went, or what type of shock it was?
That's a cardiogenic shock. Other things in terms of shock that you should know, 2 other words: compensated versus decompensated shock. Okay. So does anyone know what that means?
So one is your compensated is you're trying to make up for what's happening. So you're breathing extra, you're going faster because you're trying to make up for the loss of.
Very good.
And decompensated is when you're kind of tanking and you're going down.
Very good. Yep.
So compensating just as like faster, like breathing and pulses.
It's not a test.
Compensating.
Yep.
Yeah.
So the body's literally, it means so with any of the types of shock, you could have a compensated and decompensated kind of phase. So at first when it sets in, the body is going to respond in a way to try to make up for that lack of perfusion that we were talking about. So if I'm having a problem, say getting, let's say it's a circulation thing. So the heart rate is going to bump up and my blood pressure is going to bump up because we're going to try to push more blood out. We're going to try and push it faster and at a higher pressure to make up for that loss of blood. If I take the little bit I have and just make it move around the body faster, I can kind of compensate for a little bit for the loss of blood, say. But when we reach that decompensated state, so I think it's easiest to kind of think of these actually probably with a hypovolemic patient, but think about it, once they've lost enough blood, there's just no way that the body can circulate what little bit is left enough to make up for that loss of blood. So that's when we're going to reach that decompensated sort of state and the patient's really going to start to tank. So that's why they harp on shock so much in EMT class, is because we might be responding and the patient would be in a compensated shock state, but you have to recognize the signs that they are in a compensated shock state and I want to keep them from decompensating, right? Yeah, so that's why they're going to harp on that one a lot in EMT class, because that's our goal, is to keep them from reaching that decompensated state or to be ready in the event that they do. Okay, let's do another question. So we got a 62-year-old male with a history of heart disease, and he's complaining of chest pains. He told us that he has nitroglycerin. What should we do first? So remember, think of your answer first, then read the choices. Read the choices to see if you can get rid of any. And if you don't know how to approach it, try the 4-step method.
And think of where you are in your process.
You have a guess?
Yeah.
Okay. You guys still answering?
I know, I have my guess.
Okay. You ready? All right. Nathan, what you got?
I said D.
Okay. Jacob.
Me too.
All right. Very good. D is the correct answer. All right.
This is one of the hardest questions.
It is, it's one of the hardest, I think because people usually think,
Pete,
like, all right, well, he's got chest pain, so I'm gonna put him on I'm gonna put him on a non-rebreather because he automatically needs that. Like people would choose oxygen over anything else because oxygen is not a bad answer, but it is a bad answer. So
Yeah. Oxygen might be the answer for a lot of your things, but you know, use these methods, right? So even if you think oxygen's the right answer, use these methods like we talked about and go through and just double check and make sure the other answers are wrong and that oxygen is the best choice.
So compare this question to your psychomotor. Okay, so you've done, what have you done? You've done all the way up to what? What part are you in?
you're about to like obtain vitals.
Yeah, so you've passed ABCs, you're past your scene survey, your scene size up.
So
You've done sample because you know he's got a history of heart disease and you know he has on a prescribed inhaler. So
nitro.
Nitro.
I'm sorry,
Inhaler.
I'm praying. God, what am I reading?
I don't know.
I'm having
Not
a
the question.
stroke apparently. So, auscultating lung sounds, you usually do that when in a medical patient. One of two times, either in ABCs or in your respiratory quality and vital signs, which falls in your vital signs anyway. Does lung sounds mean anything to your nitro?
No.
No. When would you have administered that non-rebreather oxygen if you needed it?
With the like
A.
circulation.
Yep, in the A and the B. So that's way past this. You've already done that. So you can eliminate that. If you needed it, you already did it. Does he need an AED?
No.
You don't know.
Very well. I wouldn't put no AD. I've put an AD on a person who's been alive, but like usually they have to look like shit, like swirling the drain sort of thing.
Yeah. But
And
again,
there's nothing in here that says he's swirling the drain.
yeah, there's nothing that tells us this is a critical patient, so the AED.
Right now,
And
he
not
just
appropriate.
has chest.
Yeah, and the only way you can give that nitro is to
Contact vital.
No.
Yeah.
is to what? What's your answer?
Oh yeah, obtain vital.
Obtain vital signs.
Yeah.
At least the blood pressure.
But technically, don't you still have to contact vital?
Nope,
No,
you do not.
because he's prescribed. We
It's
don't have
his.
to contact.
Yeah. We didn't teach you to contact medical control.
It's what it says on the fifth tab.
Yeah, it does
It'd
say.
be
on
like
the
contact
first tab.
medical control.
Was that the right answer though?
I don't. That thing's.
I don't know.
That's a
It
little-
doesn't tell you if you
Yeah.
got the
Yeah.
answer right or not.
True. All right.
So if something's outside of your protocol, that's when you would contact medical control. Or if like, say, I've already given this patient several doses of nitro, I want to give him another one because he's still complaining of chest pain, but I'm kind of, I've reached my max of what I can give him. So then we might call medical control and then ask for permission to administer another dose.
This one's gonna be tricky for you, I think. I think.
All right, so we have an 80-year-old diabetic female who is unable to smile and has a right arm drift. Her vitals are BP 138/86, pulse of 88, respirations of 16, and SpO2 of 95% on room air. What should you do first?
It's like one of those ones that they give you, and it's like, what color what was it? What smell do you see? And then all the answers are colors or whatever.
Yeah. What does number 9 smell like?
Yeah, and one number 9
Okay.
sounds fine. All right, we have a B.
I said D as well.
You already guessed.
They said
Yeah,
B.
B.
You don't have to do that. You can do whatever you want then.
She's diabetic.
What do you know? What do you know about diabetics and strokes?
They are very similar.
They are very similar.
A.
Okay, so we got 2 guesses B, 1 guess A. Final answer, everybody?
A.
Final answer?
I still say B, but
Okay.
Nathan, final answer?
I mean, I can see my reasoning why I didn't pick some options.
All right,
Yeah,
let's do
I
that.
mean, I have
Yeah.
that.
I didn't
I'll
pick
really
A
answer
because you don't have
first.
an- you didn't take a,
You didn't take the glucose, yeah.
Okay.
and you've already assessed her mental status if she's if you asked her to smile and she's holding up her arms to the drip.
You've gotten to the point where you're doing the stroke test.
You've already done the somewhat
Yeah.
minimal stroke test, so that means her mental, she can respond to your questions.
Mhm.
And she's breathing at 16 breaths per minute, 95%, so.
Is she stable?
So-
Looking at her vital signs?
Let's use our 4-step method, right? What's her mental
Um,
Blood
status?
pressure's a little high.
What's the mental status? Let's start there.
It's altered because she's unable to perform commands.
Good. Okay, so we're altered.
And.
What's the next thing we look at?
Unable to smile.
Criticality.
So is she critical? Right.
Yeah.
Is she critical?
Based off of the stroke test, yes, because she's unable to smile, right arm drift, then her BP is elevated with,
Okay. So based on her vital signs, I wouldn't say that this is a critical patient necessarily. Okay. So you're right that she is a slightly hypertensive, but not really kind of in the concerning range
Stroke
yet,
range.
and not in the stroke range. They're going to be pretty obviously elevated if it's like hemorrhagic stroke type thing. So if she's not a critical patient, then what answer choice kind of falls away?
then B leaves and you go for A because she's diabetic and the stroke signs also fall under oral,
Yep.
under diabetic
Sounds
signs.
right.
So
Yeah.
stroke, diabetes can mimic a stroke. Yeah. So this question is, I figured would throw you off because there's no glucose, right? The glucose level. But this
Right.
is also a national test, and not everybody in the nation is allowed to do a glucometry test. So back in the days when I tested my EMT in the dark ages, we didn't do a glucose test. You couldn't perform it. So in your practical, if you had a patient who was altered and they were diabetic, you gave them insulin. I mean, you gave them oral glucose, and that's what you didn't give them insulin. You gave them oral glucose because the philosophy there was one, they didn't allow us to do it. It was outside of our scope in the national sense, and then if you're hyperglycemic, is 15 grams of glucose really going to make any difference to your hyperglycemic patient?
No.
Probably not, because it makes very limited difference to a hypoglycemic patient. So the thought here was do the oral glucose. That makes sense first. See if that eliminates any of your symptoms. If it does not, then prepare for rapid training. Then you can go to the hospital.
Yeah.
So,
And also, right, like even if we were going to rapid transport, like Andy's saying, like oral glucose is right. Is that an intervention that takes long to perform?
No.
Right. I can crack the tube, hand it to the patient, say, eat this while we're getting on the stretcher to go to the hospital. So like, rapid transport's not necessarily a wrong answer, but in terms of real life, that is what I would do, right? We're on scene with the patient. I can start treating this right now before we even get to the ambulance and start transporting. Yeah. So here, eat this, and we're going to help you get on the stretcher and go to the hospital.
Well, but like earlier, we said that they were altered, so when they like can't follow commands, you can't give them glucose.
Aha.
no, because she performed the right arm drift test. She performed the test. So that's the only reason you know she had left arm drift is if she performed it. So she performed tests.
And she smiled when you asked.
She was
No, she
unable
didn't.
to
Or she's
smile.
She's not
unable to
able to smile.
Yeah.
Why would C be wrong?
Because
Her oxygen's
her
fine.
oxygen's 95.
For a non-rebreather.
Fine.
On room air, which
Yeah.
Good. And what about D?
We've already done that.
already done that.
Exactly. Next one.
This one's not great too. I bet.
All right, a 56-year-old male is having chest pain. He's cold, clammy, and has dyspnea. His vital signs are blood pressure 116/86, pulse 56 and irregular, respiration 16. You should first All right, raise your hand when you think you've got an answer.
Why are you looking at me?
Because you keep
Like,
getting
see, we
weird looks.
stressed.
Yeah, you are stressed, it looks like.
Come sit over here.
You'd still be looking at me about like I'm making all sorts of
This is
noises
an
over here.
interesting question.
Possible answer.
Did Connor tell you we had to do presentations
No,
weekend at evac class?
no.
Yeah.
I don't have to do that.
I presented on the dangers of fatigue or of driver fatigue.
Did you get to pick?
Yeah. I put the picture in there too.
Did you?
Yeah.
What did you say?
They thought it was good.
Did they
I
know
got-
that you did it?
Yeah, I told
Oh,
them
oh,
that was part of it
oh, very good.
because we had to do a 15-minute presentation. I'm like, oh God, I
Sure.
can eat up a good 5 minutes telling the stories.
Yeah, that's good.
So you got an answer? Anybody else?
Similar to the last question, to a degree.
If he's having like labored breathing,
Just remember too, the clues or the information that you need, provided you've got the knowledge, right? The information you need to answer the question will always be in that stem somewhere.
He's a medical patient too. He has chest pain. It's an atraumatic.
All right, so let's walk through it using our method. So what is the patient's mental status?
guess he's aware.
It doesn't say anything.
Yeah.
Okay, so we're not given anything that he's altered, so we can
Assume that he is not.
yep, we can assume he's not. Okay. So next,
Well,
Is
and you
he-
know he's having chest pain, so he told you that.
is he critical or not critical?
Having labored breathing, he's cool and clammy.
Okay.
So I think critical.
Yep, I'd agree. So this is a critical patient. He's got cold, clammy skin, difficulty breathing, irregular pulse. So we're gonna go probably critical on this one. Next, what is his complaint?
Chest
Chest
Okay, good. And finally, what do our vital signs tell us?
180, 116/86 for BP, pulse 56, and irregular respirations are 16.
All right, so of those vital signs,
The pulse is
Pulse
what's
being irregular.
abnormal.
okay, what's abnormal about it?
Well, it's irregular.
It's
Okay.
irregular, it's pending on his, which we don't know his athleticism, but I mean, 56 might be low for a 56-year-old.
Yeah. Okay.
Is he in hypovolemic shock?
No.
Okay, and what tells you that? And his
Pulse.
pulse. Okay. All right. What kind of shock could he be in? Because there's a
Cardio-
pump issue.
Cardiogenic.
Okay, all right.
So can we already?
He is having a right-sided MI. All right,
Correct answer.
yeah.
All right. So
I don't know if D would be an answer. I feel like D, get rid
I
of
don't
D.
think it's A or D.
I mean, I would
I really don't
know
think it's
his
D,
prescriptions.
but you're not gonna give him a nasal cannula.
I think it's between B and C.
Chest pain.
Yeah, B and C are mine.
Think about where you are too, okay? So he's having chest pain, he's cold claiming, there's your ABCs and your chief complaint, right? You already have vital signs, which means you've already asked what?
Sample.
Sample. So if you asked sample, why would you need to determine if he has a prescribed nitro? You've already asked, right? Based on the question,
Yeah.
you're already past that. So you can eliminate that based upon your
But wouldn't you have gotten a pulse ox by that point too?
that depends. Nationally, is everyone able to do a pulse ox?
No. So then it
No.
would be A.
okay.
Would it?
No.
Or wouldn't it?
Because you can't determine a pulse, if he's saying that no one.
Well,
can-
no, because his respirations are 16. It doesn't say that they're shallow. It doesn't say,
That's
but you do know that he's having labored breathing because of the dyspnea.
Yeah. He's having difficulty breathing, and to some degree.
So I would do the nasal cannula at 4 because what if it's just anxiety and he just needs that oxygen to start out and it helps regulate. But if it goes lower, then move into the
You can-
breather.
But he's cool claiming.
He is cool claiming, but do we typically see shock per se in the hypovolemic sense where you put somebody on high flow supine blanket in a medical patient? Where do we see it?
Trauma.
Trauma.
that's
So the correct answer is what?
D.
Is what?
D.
D. Yeah. So here's the thing about this one, because it gets a little tricky with the pulse ox piece, right? So we taught you to do a pulse ox, right? But then what did we say? We said don't rely on your pulse ox to tell you what's wrong with the patient, because
Yeah.
when we taught you, like when I taught you blood glucose, what did I say? I said treat your patient, not your monitor, right? Because mine would be wrong. It could run out of batteries. Your pulse ox could be dead. You don't have any idea. And so if I am breathing like 30 times a minute and I look like shit and I can't catch my breath and I'm cyanotic, what do you think you're going to put me on? Nasal cannula or non-rebreather?
Cyanotic.
I'm tripoding. I look like crap.
Non-rebreather.
A non-rebreather, right? Because I look like that. If this man is
That
sitting
patient
there,
needs a lot of oxygen based on their presentation, right?
Right.
Their body is telling you they're starving for oxygen.
if I'm sitting here and I'm like, I have mild difficulty breathing, I'm having chest pain, that's my primary complaint. I'm mild difficulty breathing, but my respiratory rate's pretty normal. Then what do you think?
I mean, I automatically rule out the non-rebreather.
Right. So nasal cannula would be your next choice.
Yeah.
So nasal cannula is the correct choice in this. And always think about this way too. You can always go up if you need it, right? You can always go down technically, but you can start low and work your way up. So if you put him on the 4 liters of nasal cannula and it doesn't work, you can always add more or change it, But if the non-rebreather works at 10, we don't typically reduce it because we don't know if that fixed it or we're giving too much oxygen at that point. So
So you'll sometimes hear what Andy's talking about referred to as like titrating the oxygen to the patient, but that means that, yeah, we're going to do just like Andy said, start them low and kind of adjust upward as the patient's needs. So if we meet their needs, then great. We don't have to go up any higher, but in a fairly stable patient, while this one is critical, right? We determine they're critical. From what his vital signs are telling me, he's relatively stable though. Okay. So, nasal cannula. It's the best answer. All right. This is the last one.
Last one.
All right. So we have a 62-year-old male. who tells you that he has been experiencing headaches when he wakes up in the morning. He called you because he woke up today with left arm weakness. He says he bit his tongue while sleeping. You suspect A.
This is one where you have to use the context clues of the thing, and we can break it down for you afterwards. But we'll give you context clues to why certain things make sense and certain things don't make sense.
So when it says seizure due to a stroke, is that like saying like this, he would have had a seizure by this? Probably can't answer.
He had so a seizure due to a stroke would be, or seizure due to a brain tumor, or stroke due to intracranial hemorrhage, or stroke due to ischemia, means the cause of what they had is on the right. So intracranial hemorrhage caused a stroke, brain tumor caused a seizure,
So
stroke caused a
caused the
seizure, ischemia caused a stroke. Yeah. So what's on the right caused what's on the left. So the condition they have is on the left, but it was caused, its underlying etiology is on the right.
I guess.
Did you use your context clues of the words in the sentence to make that determination?
Possibly.
Possibly.
I'm gonna review my choice myself.
Got an answer. This was probably my favorite one that they broke down, actually, because it does more of the wording and less of the patient.
All right.
Votes.
Who thinks A? B? C? D? So everyone says C?
Okay, so let's break it down.
Ah,
You ready? Let's break it down. Let's break it down, okay?
It can't be A.
Is a 62-year-old male in the stroke age range?
Maybe. Yes.
Yeah.
Yes.
Yes.
Okay. All right. So you got one vote for stroke. Okay. Is a headache a sign of a stroke?
Yes.
Yes.
He been,
Has he having a headache, or has he had multiple
has
headaches?
been experiencing multiple.
Okay.
But it's not.
Is a stroke something that comes on gradually or kind of all of a sudden?
Gradually. Or no, it's all the time.
Does the stroke happen every morning when you wake up?
No.
No. So a headache being a sign of a stroke, if that was a precursor, right, then it would be that, right? So, all right, left arm weakness, is that a sign of a stroke?
Yeah.
Yes. Okay. Bit your tongue. What's that a sign of?
Seizure.
A seizure.
Seizure.
Yeah. All right. What do you think that this is something that's been ongoing for him and has gotten worse today and why he
Ongoing.
called? Or it's acute. It happened just today
He's experiencing headaches. I think it's ongoing and it just got worse today.
and it got worse today. So which of those could be ongoing? It comes on gradually, and as things change, it might cause other issues. B, yeah. So a brain tumor. So if you have a brain tumor that starts off small and isn't caught, and it grows and grows and starts pushing on things, you could have what started off as a headache that moved into arm, that moved into slurred speech, that moved into a seizure all of a sudden. So the correct answer is a seizure due to a brain tumor. Because the bit tongue would be the seizure piece of it. The other thing is a headache, stroke, not stroke, a common symptom or sign, maybe both, symptom of a brain tumor is headaches in the morning as soon as you wake up. It's a tell of brain tumors. So if you happen to wake up every morning with a headache, I'd go to a neurologist.
Morning with a headache, I'm
Okay,
fine.
I'd go to the neurologist immediately. So prime example of like a tumor getting worse and worse and worse is I had a friend who was a police officer, and he started experiencing bouts where he was dizzy, and then it increased to dizziness and kind of mild confusion, like he didn't know what was going on. And then one day he's teaching at the Coast Guard Academy, was talking and had aphasia. They didn't know what he was saying. He was completely like saying in his mind, he was saying what to do, but outwardly he was not saying anything. Like it was just jumbled. And they were like, are you all right? What's going on? And then he stopped, fell back in his seizure, and had a huge temporal lobe brain tumor. And he just got worse and worse and worse. Unfortunately, he did pass away, but his was gradual in that regard. So you could see other types of things that would mimic other things like a stroke or, things like that could lead to that. So the keys here to see are establish what a stroke is. Is a stroke acute or gradual? Does it happen right now in an instance, or does it happen throughout several days? Usually. Acute, yeah, stroke. Yeah, so acute is stroke. A stroke is acute.
Think about too, what would happen if we had a stroke that just went on for days and days and days? You're gonna die, most likely.
Right.
I mean, it's killing brain tissue, so like it literally can't happen for multiple days at a time, or the patient will die.
Right. So you have a somewhat chronic illness because he's been experiencing headaches when he wakes up in the morning. So that tells you it's more than one day. So it's a gradual onset. And then you just got to weed through everything else. So bit his tongue says seizure, left arm weakness says stroke, but you already know that stroke is not gradual. So you can probably eliminate your two stroke answers. And then you've got seizure due to a stroke. But again, we also said stroke is gradual. So then that leaves you one last, acute. So that leaves you one last answer that is gradual, and that's a brain tumor. This was a tough one too. This one had less to do with what, like vital signs and mental status and things like that, and more to do with what did they tell you was going on.
One other thing I'd say about this is I've had quite a few stroke patients, and I would say is not generally a common presentation for strokes to be accompanied by a seizure.
Not really.
I'm not saying it couldn't happen, but that's not the classical kind of presentation of a stroke. As the intracranial pressure goes up, like as the stroke is being left untreated, the seizures will happen. But typically, like he was saying, the stroke's like an acute thing that's happening right now all of a sudden. And so a seizure wouldn't be something that would set in with a stroke unless we've let that clock kind of run out and not started treating the stroke.
It's more typical to see a stroke with a heart attack or vice versa. So that does happen.